Hello, welcome to HFMA Talk, the podcast for NHS Finance. I'm Sarah Day, Policy and Research Manager at the HFMA. In this episode, I'm joined by James Kingsland, a GP and a founder member of the National Association of Primary Care, amongst many other roles. James shares his thoughts about how Covid-19 has impacted primary care and how the profession has adapted to cope. He considers the role of primary care networks and uses some of his experience in disaster medicine to think about how the NHS recovers from the pandemic. So, hello James, thank you so much for having time to speak to us today. I wonder if you could start off just by introducing yourself and explaining a bit about your role in primary care.
Thanks, Sarah. Yes, I'm a general practitioner, a senior partner in the northwest of England. I've been a GP. Sometimes we always qualify it by the time. I'm trying to think about another way of sharing the experience. I'm a GP of 250,000 consultations, I think, to date, and it's taken me about 32 years to get to that point. I also have an honorary clinical professor position in the School of Medicine in the University of Central Lancashire. I've worked as an advisor at the Department of Health in the past. I was a founder member and a previous chair and president of the National Association of Primary Care, but just have recently left that organisation. So still a clinician at heart, but a varied career in medical politics, in teaching, as well as clinical practice.
So can we talk about Covid-19 and what the impact of it has been on primary care? I'm interested in what the role of primary care has been in addressing the pandemic and the impact it's had on services.
Well, I guess there's what it should have been and what it has been, because primary care is vital in the management of a pandemic. And a pandemic is one of a number of disasters that can befall us internationally, whether it's man-made or natural. So primary care in the process of mitigation, and we've shown that we weren't very well prepared. The mitigation and preparation in whether it's the equipment that we need, the mobilisation of first contact care, and the support to the response, the emergency teams that then have to respond at the time of disaster. Probably one of the biggest issues that primary care, particularly general practice, is going to have to address, which may last a lot longer than the response time that we're in at the moment, is the recovery period. And we're already talking about reconstruction and restoration, but I'm not sure whether we fully understand the extent of that in terms of disaster management and how long that will go on for. I think already we've started to talk about the issues that are now probably coming to the fore about the impact on resource reduction. So what has happened in general practice is a very rapid change from standard general practice to more focused on one particular care area and a different way of interacting. But there has been some resource restriction because of the urgent nature of managing COVID-19. We've also got the impact of interrupted care on chronic conditions, and there's been these concern about people who might have been frightened or delayed in their routine care of other things that are challenging their health and may have serious consequences on that. And then primary care probably in the recovery phase, where we're going to have to be dealing with the sort of psychic trauma, some of the mental illnesses that will arise as a result of the stress of this time. Some of the personnel who may have some burnout, and then not least the impact of economic injury that will overspill on health. So primary care's got a big role. Whether we're addressing it as efficiently as we could have done if we'd have been better prepared, but I don't think we've ever had a response. I'm loath to use that term that everyone's using, unprecedented. We've used unprecedented so often, it's not unprecedented anymore. I think what's been unprecedented is our response. I've never experienced a response like this. Whether the disease is unprecedented in terms of international pandemics over a very long period of time, this has happened before and it will happen again. It's just this is a new virus that we have not had before, but This has happened before when we've had a virus that may have jumped over from an animal species, which was called influenza, but it was bird influenza or swine flu. So we've experienced this before, but we've never had a response. So it's the unprecedented response. And what's been shown is probably our preparation needs to be far better.
So you mentioned about people not necessarily seeking care when they needed it, or some of the concerns about people not having the support to manage their chronic conditions. So has primary care seen the same sort of drop-off in attendances as A&E, or has it been busier than ever?
No, it's been variable. From a personal view, I can say what's happened in our practice, but I have been keeping in touch with GP colleagues across the country, and there's been some consistency, albeit there's the consistency in the face-to-face contacts with general practitioners has gone down dramatically, and we've moved quite quickly to different modes of consultation, and numbers have dropped for the GP, probably not so for the practice nurse, who has a different type of procedural reviews and probably hasn't noticed a big change in numbers visiting the practice nurse. Practice managers have got much more busy. They've taken on a whole range of procedural work, and the intensity in management has probably increased, as with the general practitioner's clinical service has decreased. What has accelerated is what was always in the long-term plan about moving to a more digital based service, or the ability to have remote consultations. What's happened, the aspiration over the next 4 years has probably been delivered in 4 weeks. It's just how sustainable that will be.
How has the virtual consultations worked? Has it been embraced? Is it going well?
Yes, it's interesting whether the general public would have accepted such a rapid change and almost denial of face-to-face access if it hadn't been driven by COVID-19. But there's been a general acceptance. In the majority of cases in the early stages, it was just transferring to telephone consultations, which we'd always had in general practice. It's just the percentage of consultations by telephone had increased. Then using video has become a little bit more of the norm. And then e-consultations using different modes of interaction, whether it be email or different ways of decision support for the individual before choosing to have a consultation or not. So we've seen a whole range of new ways of working. And we do recognise that needed to increase over time anyway, as the long-term plan said. It's that there will still be a certain number that will need to revert, who are using telephone consultations, maybe photographs of their rash, for example, but there'll be a significant number of people who will need to revert to a face-to-face for obvious reasons of sometimes examination or the interaction that you need on a personal basis. We hope that the numbers, who knows, a third to 50%, that may still stay in a different type of consultation that people will accept now they've experienced it.
Yeah. So you mentioned the long-term plan, and one of the things that the long-term plan expanded was primary care networks. And a lot of work was being done around establishing them and really getting them off the ground just before this happened. So I'm interested in your views on whether the primary care networks have made a difference to the reaction to the pandemic, and in whether they have supported systems working in any way.
They've probably done both, because one of the issues around the early stages of a pandemic or a disaster is good communication channels. And the average general practice, its modal size is pretty small. It might only look after 7,000 to 8,000 people. And of course, when you have a pandemic, you have to have good communication across much larger populations. So the network has been able to provide a communication channel very rapidly between practices in a local area and help with decision making, how to manage new access, how to support each other if one practice is overloaded, how we might access equipment, PPE. So there's been an easier approach, or an easier collective approach, as a result of the networks being established. And possibly as we've then moved into creating hubs specifically to deal with patients who are likely to have COVID-19. We've been able to work collectively far more quicker because we have an established network.
And we've heard from quite a few of our members that relationships across the system have really improved through the course of the COVID-19 pandemic. Is that something that you've experienced in your own area?
Yes, I think there's the general response to disasters that brings about a camaraderie in the population, and therefore why wouldn't that happen in clinical services? There's other reasons why we'd need to work collectively to improve efficiency in response time, in having a consistency in response as well. But yes, the nature of the organisation, I think the healthcare system and the NHS does respond well to stress. There's always that concern when the stress gets too great to be efficient. But we have seen an interesting collegiate approach, which may not have been so, or we would respond that way if we didn't have to respond to a disaster.
So how do we keep it? How do we get the benefits of that?
Well, hopefully this will accelerate the process of networking, because in primary care, and primary care is a level in the system, because when I talk about primary care level in the system, it's the 4 contractor services, not just general practice. We've got our community pharmacy, oral health, and sensory services, hearing and eye care. If we can accelerate what was expected of those 4 services to work very differently in networks. So, for example, this autumn, we've just already started to receive notification about the flu vaccination programme. And to date, the NHS in primary care runs its flu vaccination programme in competition. So pharmacists and general practice are in competition. It's financially incentivised. It's part of the business. Maybe we need to rethink that. And this networking may allow us to be far more efficient without undermining the business aspects of it. So I think this hopefully will accelerate the fact that networks were designed for a particular purpose, to get the 4 contractor services, albeit on different contracts, working very differently, which we've not worked collectively in the past, but also the general practices themselves, who come together at certain times for learning, for other reasons, but now for the collective delivery of service. Only time will tell how much will survive when we have the pressures of pre-COVID NHS delivery and the increased pressures as we move into the sort of aftershock time. And it's just starting now of the recovery phase, the issues that have been brought to the fore because of this emergency, but also that delayed treatment that hasn't gone away, the delayed care. So it's going to be a challenge when we're all under pressure to deliver the full range of services that have been reduced during this particular pandemic. But how we do it is going to be intriguing. At least we've got the vehicle to do it, the network. I do hope that some of the learning we've had of collegiate working persists and therefore helps mature the networks very quickly.
So you've obviously touched on a few things that have changed and lessons learnt on the way through our conversation so far. Is there anything else that you think will mean a fundamental change for primary care going forward and how it's structured and how it works?
I think that we've touched on the 2 fundamental changes: primary care as a coordinated system of care, not just the level of the 4 contracted services, but first contact care and getting the right care. So hopefully we will start to analyse in a different way the individual's first contact and get them to the right care first time, because the right care isn't always the GP, albeit the GP or the general practice service is where the registered patient has their first contact. So I'm hopeful that the delivery system will mature far more quickly, but it was described within the primary care network and part of the aspiration of the long-term plan. The second is the ability to interact with people, advise them without having to see them, because the norm was call the GP, have an appointment, and then GP responding after the appointment going, gosh, I could have done that on the phone, or somebody else could have done it. Medicines review. Patient didn't really want to see the doctor, and the doctor wasn't necessarily the best person to do the medicines review, but they end up in the surgery with a face-to-face contact. So hopefully we will see an increased use of remote type of interactions, which we've been seeing developed in the last few weeks, and the right care. So it's not always the GP who then acts as a broker of the service. It's the right person for the patient's presentation.
And as you say, there might be, well, hopefully there will be more public acceptance of those changes as a consequence of their experiences now.
Yes, because no one can now say, I don't know how to interact in a different way. Now, there will be a small number who have probably been frightened or feeling that they shouldn't be troubling the service. And we've made it quite clear that it is no trouble to continue your necessary care. It just may be in a different way. But a lot more people have experienced a different way of interaction. So it's useful to say, well, I don't know whether I will like this. They'll have experienced it. And many will have accepted that there is a different way of interacting with their clinical service.
What are your views then on how the NHS as a whole recovers from this? And what can we learn as a health and care system from our response to this pandemic?
Yes, that's a complex and difficult area to address, because there's a whole range of things that clearly we weren't prepared for, and a huge unknown. And I've used the term aftershock quite a bit, but in the recovery from disasters, this sort of third wave of the issues. For example, in disaster medicine, it's well known that the mortality is usually greater in the recovery phase rather than in the response phase, and not related to the disaster. So we may have more injury or more injured people, more ill people, not related to COVID-19, but as a result of COVID-19 and our response to it. So the NHS is going to have to address a lot of the consequences which may be the economic recovery and the economic injury, because interestingly, whilst there's been the line that COVID or the SARS virus, the coronavirus, does not discriminate in who it affects, which is fair comment, but it completely discriminates in the after effect. So whether it discriminates, we know, in race, in debility, and it will discriminate in economy as well. So that some people will have a far greater impact because of their livelihood, and therefore their inequality and possibly their health inequality will be made worse. So the effects of people because of the economic injury, and that's a big unknown. Whether the NHS is prepared for it, we know we've built capacity in the system through the actions of having more emergency care in hospitals. One of the learnings is what do we do with the Nightingale hospitals? That has created increased capacity, but they've not been required. But should we hold on to them? So, for example, probably before my student days, it was not unusual to have fever hospitals probably before the NHS, hospitals specifically, because they were required at that time. Should we have something, or can we afford to have something that deals with pandemics and is ready to go for the next one, as opposed to, we might close all of our Nightingale hospitals in the next 12 months. And then when this happens again, because it will happen again, and that's not being histrionic, 2014-15, 28,000 souls lost their lives in 2014-15 through the influenza epidemic at that stage. And that's vaccinating 14 million people. We still lost 28,000 people. I know we've lost over 35,000 now from COVID-19, but that's without vaccination. Just imagine what would happen if we hadn't have vaccinated 14 million people of the most vulnerable. So should we still have a service is ready for the next? So we don't have to go and build Nightingale hospitals. We have one or two of these facilities ready for a pandemic. So the learning from this is going to be quite extensive. I think what we've learned is that we need a much better approach to preparation. So, for example, I've been saying in primary care, every year we have our training events, we have our protected learning times. Maybe the primary care network now should put in place that twice yearly we have a rehearsal for emergencies. And it may not just be a pandemic, it may be other forms of emergencies that could befall a community because they're living next to a power station or a chemical plant or something that might happen. But during my time in practice, we've not done that. We've not prepared with the right equipment. We've seen that within our emergency services in hospital, or the protective equipment that personnel need. So if we must learn from a whole range of things about how we in future mitigate against disasters, how we better prepare for them, as well as the response time, and what we learn from the next 2 to 3 years as we recover and hopefully build back better. Not my term, but from disaster management, the build back better process is something that was coined by the Sendai framework. The WHO produced a framework from a conference in Sendai in Japan. The Sendai framework is well known throughout the world in the disaster management community. We probably should take note of what that tells us in terms of how we manage disasters. This framework was created in 2015, and it was a call on all governments to be better prepared for disasters. We've demonstrated that if we talked about the Sendai framework, I would say the majority in the NHS would never have heard of it.
Do you think we would have reacted to the pandemic differently if we'd thought about it as a disaster from the beginning?
Possibly. And it's interesting when you use the term disaster, it's often quite emotive, a description of all sorts of terrible things that go wrong, as opposed to a discipline, which of course disaster medicine is an area of medical specialisation. And disaster management, as described in the Sendai framework, is a process to help manage when something befalls us like a pandemic. So probably we should use that term more, disaster, because it links in with a discipline which we required since the turn of this year, and we will require again. So I think disaster management is probably the right term, and we should use less emotive terms which frightens people, because a lot of people have got frightened, not least because of the media coverage that have used very emotive terms. But yes, I think disaster management is the right term for one disaster is pandemic. There's lots of other types of disaster, but that would probably bring it into a more disciplined and then recognised area of medical specialisation.
Thank you for your time today, James. It's been really good to get a different perspective on the pandemic and to hear more about what primary care have been doing in response to it. So thank you for that.
Been a pleasure. Hopefully listeners gain something from it.
All of the HFMA's COVID-19 related briefings, blogs and news articles are openly available on our website, hfma.org.uk. There is no need to be a member to access these, so please tell your colleagues. We have also launched a forum where finance colleagues from across the NHS can discuss issues and challenges in a safe space. You can sign up via the link in the network section on our website. If there are particular topics that you would like future podcasts to cover, then please get in touch via our email address, policy@hfma.org.uk. Thank you for listening to HFMA Talk. Don't forget to subscribe to this podcast to keep up to date with new episodes.